Все, спасибо большое. Все, спасибо. So, good day. Today our lectures, two lectures, esophagus cancer and esophageal cancer and gastric cancer. Esophageal cancer. We begin from esophageal cancer. Anatomy of the esophagus. Segments of esophagus. Trachea, aortic, tracheal aortic, intra-aorta-bronchial, bronchial, bronchial, subbronchial, retrocardial, supraphrenic, diaphragmatic, and subphrenic. Pathways of lymphatic drain from the esophagus. Diagram. From the upper third blue, from the upper, from the middle third pink, and third it is the lower third. APC ways of lymph outflow from different parts of the esophagus. Risk factors. Tobacco intake and alcohol, consumption, fruits, vegetables, fresh meat, fresh fish, riboflavin, nicotinic acid, beta-carotene, vitamin A, C, B, magnesium, and zinc. Other factors is asbestosis, ionizing radiation, drinking hot drinks, excessive mineralization of water. Precancerous disease of esophagus. Leukoplakia, achalasia, Barrett's esophagus, acid damage to the esophageal diverticulum, ulcers and polyps. Esophageal polyp. Benign polyp, but it is precancerous disease. Barrett's metaplasia, Barrett's esophagus we told, is a precancerous disease of the esophagus. Malignancy in 16 to 23% from all cases of esophagus cancer. Barrett's esophagus in a state of malignancy. Classification of esophageal cancer by growth form. According to the form of growth, esophageal tumors are divided into exaphyte 30 to 35%, and in the feet 60 to 65%, and the last is mixed. Mesomorphic growth. exophytic growth. Ulcer growth, ulcer form. Squamous cell carcinoma of the esophagus. This is squamous cell carcinoma. Barrett's adenocarcinoma. Barrett's adenocarcinoma, the same. Adenocarcinoma. Esophageal cancer classification by TNM classification. T, as we know, primary tumor. TX, no incidence from the primary tumor. T0, primary tumor is not detected. T in situ, TS, mean in situ, it means carcinoma in situ. T1, tumor infiltrates the basement membrane or submucosa. T in situ, it means the tumor is not invasive through the basement membrane. T1, tumor infiltrate the basement membrane or submucosa. T2, the tumor infiltrate the muscular layer. T3, tumor infiltrates adventita. And the last is T4, tumor spread to adjacent structures. Lymph nodes, original lymph nodes, in X, no evidence lymph nodes, metastasis. In 0, no signs of regional lymph node involvement or metastasis. In 1, regional lymph node metastasis. And the last is M, distant metastasis. MX, no evidence distant metastasis. M0, distant metastasis are not detected. And M1 has distant metastasis in other organs. G, it means grading, histological grading. Gx, the degree of differentiation cannot be determined. G1, high degree of differentiation. G2, average degree of differentiation. G3, low degree of differentiation. And G4 is undifferentiated tumor. Grouping by stage. Stage 0, it means T in situ in 0 in 0. Stage 1, it means T1 in 0 in 0. Stage 2, it means T2 to T3 in 0 in 0. And stage 2B, T1 to T in 1 M0. Stage 3 mean T3 N1 M0 or T4 any NM0. Stage 4 divided to stage 4 A and B. Stage 4A, any T, any N, M1A, and stage 4B anti-NEN in M1B. Clinical manifestations of esophageal cancer. Symptoms of damage to the esophagus, general symptoms, symptoms of involvement of neighboring organs in the pathological process. Symptoms of lesions of the esophagus associated with narrowing of the esophagus and impaired patency. Dysphagia, feeling of fullness behind the breastbone. Increased saliva flow, unpleasant sensation in the mouth, nausea, regurgitation, bad breath, and pain. Stage of dysphagia, stage 1, 2, and 3, stage 1, 2, 3, and 4. The first stage, difficulty swallowing solid food. In this case, a person has to constantly wash down the eaten pieces of food. Stage 2, difficulty in swallowing mushy, semi-liquid food, porridge, mashed potatoes, and the same. Stage 3, difficulty in swallowing liquids, water, tea, and the same. And stage 4, complete obstruction of the esophagus. General symptoms, fast fatigability, reduced performance, weight loss, anemia, temperature increase, sleep disturbance, bleeding, inflammation of the tumor, decrease in power, dehydration, thickness of blood. Symptoms of spreading to neighboring bodies. Retain nerve damage, cough at distribution on plank, letting the sympathetic barrier, pneumonia, lung abscess, empyema of the pleura, pericarditis, mediastinite, bleeding from large vessels. Esophageal cancer symptoms, frequency in percent, dysphagia, 87 to 95%, weight loss, 42 to 71, nausea, vomiting, 29, 45, pain, 20, 46, cough of wheezing, 7 to 26, cachexia, to 6%, and dyspnea to 5%. Clinical forms of esophageal cancer, laryngeal tracheal, cardiac, pleural pulmonary, gastric, neuralgic, and mixed. X-ray symptom of esophageal cancer. Endophytic cancer of the middle third of the esophagus. Narrowing of the lumen of esophagus. Radiologic symptoms of esophageal cancer. Violation of the relief of the mucosal membrane of the esophagus. computed tomography in the diagnosis of esophageal cancer. Esophageal cancer with subcarinal lymph nodes. Cancer of the middle third of esophagus. Fibroesophagus. Cancer of the middle third of the phagus. Treatment. Standard treatment regimens for patients with esophageal cancer, cervical and upper thoracic. Stage 1 to 3, no dysphagia. Radiation therapy, 2 courses with an interval of 2 weeks. B. Chemotherapy, 3 to 6 courses at intervals of 2 to 4 weeks. Stage 3, with stage 4 dysphagia, symptomatic surgery, radiation therapy, 2 courses with an interval of 2 weeks, chemotherapy, 3 to 6 courses at intervals of 2 to 4 weeks. Stage 4, no stage 4 dysphagia, chemoradiation therapy, courses with an interval of 1 month, 2 courses with an interval of 1 month, B. Chemotherapy, 3 to 6 courses with an interval of 2 to 4 courses. Stage 4, there is stage 4 dysphagia, symptomatic surgery, chemoradiation therapy, 2 courses with an interval of 1 month, chemotherapy, 6 courses at intervals of 2 to 4 courses. Standard treatment regimens for patients with esophageal cancer, middle, lower, thoracic, and abdominal regions. Stage 1 to 3, no, you understand, stage 1 to 3, it means T1, 2 to 3 in 0 or in 1, depending on the stage, first, second, and third stage. Radiation therapy, surgical treatment. Stage 3, tumor resection possible, radiation therapy, surgical treatment. Stage 3, tumor resection is not possible, no for dysphagia and esophageal fistula, radiation therapy, 2 courses with an interval 2 weeks, chemotherapy, 3 to 6 courses with an interval 2 to 4 weeks. Stage 3, tumor resection is not possible. There is stage 4 dysphagia, symptomatic or palliative surgery, radiation therapy, 2 courses with an interval 2 weeks, chemotherapy, 3 to 6 courses at intervals 2 to 4 weeks. Stage 4, no stage 4 dysphagia and esophageal fistula, chemoradiation therapy, 2 courses with an interval of 1 month, chemotherapy, 3 to 6 courses at intervals 2 to 4 weeks. Stage 4, there is stage 4 dysphagia, symptomatic or palliative surgery, chemoradiation therapy, 2 courses with an interval of 1 month, chemotherapy, 3 to 6 courses at intervals 2 to 4 weeks. Stage 3 to 4, there is an esophageal fistula, symptomatic surgery. Operations. The first operation, Dobromislav Torek, as we see here, thoracotomy. Crossing non-paired veins. Esophageal mobilization. Esophageal transection. Withdrawal of the neck esophagus through the wound of the neck and formation of esophagostoma. The final view of the first stage of the operation. The second stage of operation, plastic surgery of esophagus by the large intestine. Skin line incision at a garlic operation, next operation. In lower part of esophagus, localization, lower part of esophagus. Diaphragmotomy, esophageal transection, no, finished type of operation. And this diaphragm, stitch the diaphragm. The prepared type of removed preparation in garlic operation, part of stomach, and here we see the tumor, lower part of esophagus. Louis operation in middle part of esophagus, localization middle part of esophagus. 2 incision, laparotomy and thoracotomy. Mobilization of the stomach from the laparotomy. It is the stomach. Dissection of the mediastinal pleura, front and back of the esophagus. Excretion of the esophagus with the surrounding cellulose and lymph nodes. Separation of the back wall of the esophagus from the aorta. Crossing and lightening of the esophageal branches of the thoracic aorta. Crossing and lining of a non-paired vein. Mobilize stomach in the pleural cavity. Location of esophagus cross. Formed stomach stump. Instrumental circular stapler. Removable stapler head in the esophagus. The stapler is inserted into the stomach through pylorotomy incision. Removable head and stapler connection. The final view of Lewis operation. Streinsen-Kader gastrostomy. Gastrostomy, indication for gastrostomy. The patient had stage 4, esophageal cancer stage 4, with complete stenosis. Laser recanalization of the esophagus before the intervention. Laser recanalization of the esophagus. Laser recanalization of the esophagus after the intervention. Esophageal stents of different sizes. Different sizes of stents. Stenting of esophageal stenosis. Stenting of esophageal stenosis. Left, tumor stenosis of esophageal. And right after stenting of stenosis. Covered Z stent. See also stent descriptions. Adjuvant chemotherapy regimen for esophageal cancer, fluorouracil 1000 milligram, days for Fortis platin, Thank you for your attention. Next lecture is gastric cancer. Wait a minute, please.
Какая у вас аудитория была?
4. Все, да? Спасибо.
Проверю еще раз. Всё, почему
Мгм.
идет трансляция.
Спасибо. So, we'll continue our lecture. Next lecture is gastric cancer. Features. Most gastric cancer patients present with advanced disease. Early gastric cancer account for only 5 to 20% of all gastric cancers. Even patients who present in the most favorable condition and who undergo curative surgical resection often die of recurrent disease. Stomach anatomy of stomach. The stomach has 3 parts: cardia, body, and pylorus. The stomach wall is made up of 5 layers: mucosa, submucosa, muscular layer, subserosal layer, and serosal layer. The peritoneum of the greater sac covers the anterior surface of the stomach. The vascular supply is derived from the celiac artery branches, from left gastric artery, common hepatic artery, and spleen artery. The lymphatic drain of the stomach is complex. Epidemiology. Incidence. Highest rate is noted in Japan. 85% from 100,000 population. Korea, China, and Taiwan have very high rates, to 32 and 3 to 39 and 9 per 100,000 population. Lowest incidence, less than 3.7 cases per 100,000 population, is noted in North America, Western Europe, and Australia. Large change since 73 involve the decline in stomach cancer incidence rate. Epidemiology death rate. Gastric cancer is the second most common cause of cancer-related death in the world. The highest death rates are noted in Costa Rica, behind 67%, Japan, behind 54.6%. The lowest death rates are noted in USA, Cuba, and Kuwait. The rates of gastric cancer are higher in Asian countries than in the United States. 6. Gastric cancer afflicts slightly more men than women. The male to female ratio for gastric cancer is 3 to 2. Age, the median age diagnosis in 55 years, range 40 to 70 years. The gastric cancer that cure in younger patients may represent a more aggressive variant. Causes. There are 3 main groups of factors predisposing for incidence of gastric cancer. Alimentary, diet factors, familial or hereditary factors, geographical factors, likely climate, contents of microelements in the water and in the ground, as for example geographical factors as gastric cancer and esophagus cancer in north of China. The causes there because the ground is deficiency microelements. Other factors: Helicobacter pylori infection, previous gastric surgery, precancerous disease. Pathophysiology. There are two conditions for the development of gastric cancer. Influence of carcinogenesis on the gastric mucous membrane, influence of carcinogenesis cancerogens on the gastric mucous membrane, presence of proliferation processes with metaplasia and dysplasia. Which become to malignancy at the last stage. Histological findings. Adenocarcinoma, 90 to 95% of all gastric malignancies. The second most common gastric malignancies are lymphomas. Leiomyosarcomas, 2%, and carcinoids, 1%, are the remaining tumor histologic types. Macroscopic forms. The first is exophytic cancer. Likely polypose and fungus. Braces borders. Slow growth. Cells may spread to 6 centimeters from the visible tumor borders. Endophytic tumor. Diffuse infiltrative and ulcer infiltrative cancers. Rapidly growth without braces borders. Malignant cells spread to 10 12 centimeter from the visible tumor borders. Third is mixed form. Is exophytic component combines with infiltrative growth. Type 1 tumors are polypoid or fungitation, clearly demarcated, may be ulcerated, have late metastasis, have relatively good prognosis. Macroscopically, there are exophytic forms. Type 2 tumors are ulcerating lesions, ulcerar cancers, surrounded by elevated borders, sharply defined margins, difficult to differentiate it from benign ulcer on gross examination. Requires biopsy, have a relatively good prognosis too. Type 3 tumors have ulceration with invasion of the gastric wall. Lacks clear-cut margins, extensive submucosal infiltration, extends to the serosum. These tumors are not most common type of gastric cancer with relatively poor prognosis. Type 4 are diffusely infiltrating linitis plastica, leather bottle stomach. This type have early metastasis with poorest prognosis of all gastric cancer. Type 5 cannot be classified. Localization of the tumor. 40% of cancers develop in the pyloric part of stomach. 40% other in the middle parts of stomach body. 15% in the upper part of stomach, cardia part. 10% involve more than one part of the organ. Cancer of the stomach can spread by 3 ways. Directly, via lymphatics, via blood vessels, hematogenously. The staging and TNM classification for gastric cancer. T is tumor. T1 mucosa or submucosal layer, invasive. Tumor invasive to mucosa or submucosal layer. T2 muscular or subserosal layer. T3 to serosal layer. T4 involve another organs. Lymph nodes metastasis, regional lymph node metastasis. From 1 to 6, it means in 1. In 2, from 7 to 15 lymph node metastasis. And in 3, more than 15 lymph node metastasis. M, it means distant metastasis. The first organs from the stomach, the metastasis spread to liver and or lung, or both of them. Stage grouping for gastric cancer and 5-year survival rate. As we see here, stage 1A, 1B, one A T1 in 0 in 0, 1B T1 in 1 in 0, T2 in 0 in 0. 1A 88%, 1B 75%, 2 is 65%, 3 stage divided to 2 subtypes, A and B. The A stage, 3A stage 35%, and 3B stage is 10%. And the last stage is stage 4. The survival rate, 5-year survival rate is 5%. Early cancer symptoms, termed as small signs of gastric cancer syndrome. The first or general symptoms: weakness, diminished ability to work, unpleasant sensation and heaviness in the stomach, physical depression with no apparent cause, loss of pleasure from food, change taste of food, aversion for some kind of food. Advanced cancer symptoms: indigestion, nausea or vomiting, depending on localization of the tumor, dysphagia, postprandial fullness, loss of appetite, and weight loss. In carcinoma of the pylorus, sense of fullness in the stomach, vomiting the food taken the day before, musty smelling, regurgitation. In the cardiac cancer, sensation that solid food sticks in the gullet. On stomach body cancer, hyperchromic anemia. Clinical manifestation. There are 4 the most common distant metastases of gastric cancer. The first is Verkam's metastasis on the left supraclavicular area, Schnitzler's metastasis on peritoneum, pouch of Douglas, Sister Mary Joseph metastasis in umbilicus, and the last Krukenberg metastasis on ovary in woman. Clinical manifestation gastric cancer complications. The most dangerous complication is bleeding from the ulcerative form of gastric cancer. Late complications, pathologic peritoneal and pleural effusion, obstruction of the gastric outlet, gastroesophageal junction or small bowel, bleeding from esophageal bleeding from esophageal varices, jaundice, inanition from starvation or cachexia of tumor organ. Differential diagnosis: benign neoplasms, gastric ulcer, because peptic ulcers and gastritis cause similar findings. Diagnosis is often delayed. Jaundice and hepatomegaly if there are hepatic metastases. Pelvic masses in women if there are Krukenberg metastases. Diagnostics: in patients with suspected gastric carcinoma, it is necessary to begin the evaluation with history taking and physical examination with palpation of abdomen, navel region, left supraclavicular region, Werfer's metastasis, rectal and vaginal investigation, Schnitzler or Krukenberg metastasis in womb. The next step of examination are X-ray and esophageal gastroduodenoscopy. Early gastric cancer in X-ray, the type 1 lesions are elevated and protrude more than 5 millimeters into the lumen. Type 2 tumors are superficial lesions with R elevated stage 2A, flat stage 2B, or depressed stage 3. Type 3 early gastric cancers are shallow, irregular ulcers surrounded by nodular, clotted mucosal folds. Advanced gastric carcinoma. Abnormalities in the gastric contour or as soft tissue masses indenting the gastric contour. On barium studies, advanced gastric carcinomas may be polypoidal, ulcerative, and infiltrating lesions. Polypoid carcinomas are lupulated masses with protrude into the lumen. Seen in profile, these lesions are intraluminal, whereas benign ulcers project beyond the contour of the stomach, ulcerative form. Infiltrative carcinomas results in irregular narrowing of the stomach with nodularity or speculation of the mucosa. Carcinoma of the cardia are often missed during single contrast examination. Esophageal gastroduodenoscopy. Endoscopy has become the diagnostic procedure of choice for patients with suspected gastric carcinoma. Biopsy samples obtained during endoscopy enable histologic diagnosis. Biopsy specimens can be obtained by pacing forceps and taking small mucosal samples for histology studies. Multiple biopsy specimens are needed to avoid sampling errors. Computer tomography CT scan of abdomen is primarily used to preoperatively assess patients with gastric carcinoma. CT scan is to assess the presence and extent of extragastric spread. This information is vital in discerning between palliative surgery and curative radical surgery. Though CT scan is used to lymph nodes and distant metastasis stage, and also to monitor the response to treatment. Lymph node staging. CT scan depicts 75 lymph nodes. Intraperitoneal and omental metastasis consist of nodules, localized fluid collections, and irregular thickening and stranding of the mesentery and omentum. Transabdominal ultrasonography of the stomach. The primary route of transabdominal ultrasound is to detect liver metastasis. Endoscopic ultrasound, this study also for a more precise preoperative assessment of the tumor stage. Positron emission tomography PET depicts the primary tumor but involved perigastric lymph nodes are not identified separately from the primary tumor. Chest radiograph. This is done to evaluate for metastatic lesions. Laboratory studies, complete blood cells, can identify anemia, which may be caused by bleeding, liver dysfunction, or poor nutrition. Electrolyte panels and liver function tests also are essential to better characterize the patient's clinical state. Surgical care, treatment. Surgical care, there is one most common principle in surgical care of gastric cancer. Small tumor is need performed extensive operation. Type of surgery, in endogenous gastric cancer, total gastrectomy, or esophageal gastrectomy for tumors of the cardia and gastroesophageal junction. As total gastrectomy presence at the edge of resected specimen esophageal and intestinal epithelium are the criterion of redness of gastrectomy margin. subtotal rejections of stomach for tumors of the distal stomach and in exogenous gastric cancer. The criteria of the type of operation, gastrectomy or subtotal resection, are localization of tumor, macroscopic form of tumor growth. What here? The tumor subtotal resection with lymph dissection. During the operation, it is necessary to perform subtotal resection of stomach or gastrectomy beyond the bounds of microscopic borders of tumor to remove in one block regional lymph node dissection, removed laser omentum during gastrectomy in case of indefective. Complication after surgery, early post-operative complication, anastomotic failure, bleeding, alias transit failure, at the anastomosis, cholecystitis, pancreatitis, pulmonary infection, and thromboembolism. Late mechanical mechanical physiologic complications, dumping syndrome, vitamin B12 deficiency, reflux esophagitis, and bone disorders, especially osteoporosis. Adjuvant therapy. Adjuvant therapy, radiotherapy, is sometimes useful in relieving a localized area of obstruction, particularly in the region of the cardia, and for patients with chronically bleeding cancers, then cannot be resected. Chemotherapy, anti-metabolite 5-fluorochetil has been used most frequently. Now, most effective and safe medicamental form of 5-fluorochetil is Xeloda, capecitabine. Other combinations include 5-fluorochetil, adriamycin, and metamycin. The 5-year survival rate for curative surgical resection range from 30 to 65% for patients with stage 2 disease and from 10 to 35% for patients with stage 3 disease. Thank you and goodbye.